Welcome to another episode of the NEI podcast. I'm Dr. Sabrina Siegel with the Neuroscience Education Institute. In today's episode, we are coming to you from the 2023 NEI Synapse in Nashville, Tennessee. Today, we sit down with one of our incredible speakers in this special extended Q&A episode to give you a chance to get your unanswered questions addressed from selected presentations. In this episode of the NEI podcast, we are coming to you from Nashville, Tennessee. This is an exclusive extended Q&A episode where Dr. David Goodman just came off stage and presented his incredible talk on ADHD. His talk was titled ADHD, Optimizing Treatment and Patient-Centered Care. Welcome, Dr. Goodman.
Hi, Dr. Siegel. Glad to be here.
Excellent. This is our chance to let the audience have some of their unanswered questions addressed. So the very first question that I have for you is, I have been in practice for about 40 years, and a lot of my ADHD patients have stayed with me. Now they're in their 60s and 70s and really like their stimulants, but are now developing hypertension, etc. Do you have any suggestions? And also, how do we navigate issues with stimulant prescriptions in older adults, 65 and older, who've been on stimulants for many years, considering the FDA guidelines?
So these are great questions. We have patients who have ADHD as they get older. And I'm grateful to the person who asked the question, having been in practice for 40 years. The fact that his patients have stayed with him is a credit to his skill. And also imparts the importance of continuity of care with the same provider. So to be able to not only have the relationship, but to see how the symptoms of a psychiatric condition change or persist over the course of time. In regards to older adults with ADHD, there's a modicum of research out of Amsterdam, and I'm actually the first author on the first literature review of this topic.
Wow.
The way to do this is to understand first that ADHD doesn't go away as you get older. And so maintaining patients who have had a good response on their ADHD medication is very legitimate in their 60s and 70s and 80s. Now, as these older patients age, there are cardiac issues, which is the one that we specifically are looking at. And the question addressed hypertension. But whether you're prescribing the stimulant comes down not so much to the hypertension as it does to quality of life. And the other question is, to what degree is the hypertension provoked by the stimulant and or is related to other factors? Typically in a discussion with my older patients, and this comes up, we monitor blood pressure and we go ahead and get the blood pressure treated. Reducing the dose might be helpful, but if you lose efficacy, you're going to compromise daily performance and quality of life. So unless there's a major cardiac issue for which patients can't be on stimulants, and that has to do more specifically with arrhythmias, I generally focus on maintaining the functionality of the patient while the other medical conditions get taken care of. And hypertension is relatively easy to take care of. It's when you get other cardiac issues like post-MI or patent ductus ovale, right bundle branch block. Those are issues for which I coordinate my care with a cardiologist.
Okay.
In regards to the FDA guidance, it's not so much FDA guidance as it is the clinical protocols that get submitted to the FDA for approval. If you look at all of the ADHD medications, the protocols generally go up to 65, except for lisdexamfetamine, which was 55. And so we don't have very many high-quality control trials of stimulants in these older adults, and the clinicians are just trying to make their best judgment. It used to be that getting reimbursement through Medicare for stimulants was problematic, but over the last many years, I've not found that to be as much of an issue as patients are getting approval for their medications. So the insurance limitations don't seem to be there in the same way it was. Just because the FDA puts a maximum age, it's not based on safety. It's based on the clinical protocols that were submitted, and the protocol simply went up to 55 or 65. I think if you accumulate the literature and you pull my review article, there's another review article out of the Amsterdam group, you'll have enough basis upon which to feel clinically reassured that you're on solid ground when continuing the prescriptions.
Thank you for sharing that with us. The next question is, do you have a preference for stimulants if the patient also has a diagnosis of Tourette's or motor tics?
So I don't have a preference, and I'm not sure whether there's a differential between methylphenidate and amphetamines in the provocation of new tics or the worsening of pre-existing tics. There's old literature in the child ADHD arena with Concerta, and as I recall, 40% of the tics got better, 40% of the tics didn't change, and 20% had an increase in tics. So the Tourette's or motor tics themselves are not a contraindication, but you want to monitor as to whether or not they get better, worse, or stay the same. You're not necessarily going to know that a priori, and that is you have to prescribe to see what happens. From there, I will generally add a alpha-2 agonist. Now, if they have pre-existing Tourette's or motor tics, I might try an alpha-2 agonist first, both for the tics and for some improvement in ADHD.
Gotcha. Okay. The next question is, how does the clinician differentiate ADHD from anxiety-promoted inattention and impulsivity? That's a great question.
Well, that is a great question, because you have to make these differentiations not solely on symptom checklists of what we use for anxiety. I was trained as a phenomenologist. That means I explore the psychological experience in order to tease out what's going on. So that sounds very abstract and obtuse. Let me give you an example. If you've had headaches, if you've had migraines, you can tell the qualitative difference between a tension headache, a migraine headache, and a sinus headache. Even though they're all headaches, they're qualitatively different. So what we try to do in psychiatry is we ask questions about the mental, emotional, and physical experience, and then decide, is this anxiety because it's fueled by a sense of worrying and impending doom and something's going to go wrong? Or is this an internal physical restlessness for which there's no associated worrying? That's how I make the distinction. Also, the other aspect of this is, how do you differentiate ADHD and secondary anxiety from the ADHD based on performance and impairment? Or how do you differentiate ADHD and a primary anxiety disorder? So I'm about to say something that's entirely clinically based, and there's no research to support this. But what I do is I look at the content of the worrying. If people are worrying, if people with ADHD are worrying about getting to someplace on time and being forgetful, that anxiety is probably tied to the ADHD. If they're worried about contamination fears and medical illnesses, then that's probably a primary anxiety disorder with ADHD. So that's what I mean by phenomenology of psychological experiences and trying to sort it out based on that method.
The next question is, what is your recommendation for ADHD treatment for individuals who have a history of substance abuse or are currently abusing substances?
So also a good question for clinicians. I'll break this out into two categories. One is those who have a history of substance abuse, and then segment that into how long have they been in recovery. Is it a year? Is it 10 years? And the other category would be those who are actively misusing or abusing drugs and what drugs they're making use of. And in that category, then you have to segment out those who have recreational use or binging on alcohol or other drugs, and those who are having chronic daily use. So it's easier to address the current misuse by saying, look, these folks are using drugs that are affecting their cognition. You're going to have a hard time sorting out what cognitive symptoms are a function of the substance abuse, concomitant substance abuse, and which is a function of the ADHD. So we try to get them off the substances they're abusing. Now, if you're using marijuana 2 or 3 times a week at night, I'm not particularly bent out of shape on that. We're going to encounter an increasing use of marijuana as it gets legalized in more and more states. So we will just have to deal with that.
Right.
For those people, though, with ADHD, if their recreational use is mild to moderate, then I'll treat the ADHD. And there's some evidence to suggest that you actually can reduce the recreational use. The daily misuse or abuse is more problematic, and treating the ADHD may or may not actually reduce that. For those then who go into substance abuse recovery, there was a study published about a year or 2 ago looking at those with ADHD and substance abuse with and without ADHD, with ADHD, with or without ADHD medication. If you were in substance abuse, had ADHD, and you weren't treated for your ADHD, you had a 5-fold higher risk in 3 months of relapsing.
Wow.
Versus those who had their ADHD with medication who are in recovery. So we have to rethink this in regards to, you treat substance abuse first and then ADHD, or do you treat them concomitantly? The other category was the history of substance abuse. And so it depends where they are in their recovery, how actively they're working, what kind of supports they have. The idea that prescribing stimulant medications for somebody who has ADHD in recovery is going to provoke a relapse, there's very little evidence to support that. So I think that that's a clinical impression that is not well founded in the research. And for those people, if they have ADHD and they've never been treated, I would go ahead and treat their ADHD with the usual medications and just monitor their recovery program.
The next question is, what is your thought process when adults come in looking for an ADHD diagnosis and do not have a history of diagnosis in childhood? What are your thoughts?
I think, to be conservative, the diagnostic criteria really anchors ADHD in childhood and early adolescence. So if I'm not able to get a history of those symptoms, and somebody comes in at 27 years old and says, I've been having this problem for the past couple of years, but I didn't have it 5 years ago, 7 years ago, this person doesn't have ADHD. The person with ADHD typically will say, I've always been like this. I can't remember not being like this.
Right.
It's unlike mood disorders that are cycling. So the mood disorder patient who gets better says, well, I'm back to how I used to be. The ADHD patient who gets treated says, I'm so much better. I've never been in this state of mind. You want to anchor the diagnosis in childhood and early adolescence. Now, there's a big debate as to whether there's adult onset. So in the literature, there's late onset ADHD, which means that the symptoms didn't present until the patient was 13 years and older. And then there's adult onset, where the symptoms didn't present until they were over age 18 and older. I think, to be conservative, you really need to anchor the diagnosis in childhood and early adolescence. Does that mean that patients with attentional problems won't benefit from stimulant medications? No, they probably will. But then you have to be sure that you're prescribing for a medically legitimate reason and not simply because somebody wants stimulants to enhance their performance.
That's great. The next question is, aside from a thorough patient interview, what do you recommend for ADHD workup in adults? Screening tools, functional testing, psychological testing? What do you recommend?
So I typically use the adult ADHD self-report scale. It's the 18 symptoms out of the DSM-5. It's a frequency-based 0 to 4 rated by the patient.
Okay.
The symptom count threshold is 5 of 9 inattentive and or 5 of 9 hyperactive symptoms. So you do the rating scale at baseline, and then periodically as you're instituting treatment in order to track a reduction in the frequency of the symptoms. But then you follow up that question survey with the question, how is this improving your functioning during the course of the day? Because you want to blend both the symptom reduction and the functional improvement. So that's how I do that. In regards to neuropsychological testing, I don't routinely order testing. I will use neuropsychological testing in order to sort out intelligence if I have a question. Learning disabilities, audio, visual, processing, math, reading, or executive function, specifically working memory, organization, sequencing, tasks of that nature. But I don't routinely order neuropsychological testing for this reason. If you get a test result that says we don't see much in the way that would substantiate ADHD, then you have to live with those results. If your clinical history is in contrast to the neuropsychological results, then you treat the patient clinically and put aside the neuropsychological testing. So we can't rely on the neuropsychological testing to either make the diagnosis or even confirm the clinical impression of the diagnosis. And that's why I don't use that. Other functional testing, I know there are tests out there, but I just tend not to use them. The CPT, continuous performance testing, for attention on a computer-based task also falls to the same shortcomings. And that is, if you get positive results, you can affirm the ADHD. But if you get negative results, you can't disregard the clinical history. So I'm not sure I find those useful. Now, you might want to use those tests for the patient so that they can see the difference on and off. And maybe for some patients, an objective test is confirmatory for the benefit of the treatment.
Okay. Well, that takes me to our last question, which is there a reason why you couldn't use viloxazine with an SSRI for someone with major depressive disorder and ADHD?
There is not. And viloxazine with a SSRI, it can be used and has been used. Remember that viloxazine has a strong inhibitory effect on the 1A2 isoenzyme. So anything that goes through there is the metabolism is going to be inhibited. What would those be? Clozaril. Well, you're not going to be using Clozaril in ADHD individuals. Caffeine, though. So if you use viloxazine, you will reduce the metabolism of caffeine. And so you'll get a bit of a stronger effect and it'll last longer.
Wow, that's so fascinating. Thank you so much, Dr. Goodman, for joining us and for giving the audience an extra chance to get some of their questions answered today.
Thanks, Sabrina. Glad you invited me. This was great.
Thank you so much for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today.